All right. Well, welcome everybody. I'd like to welcome Dr. Nafisa Reza. She is and welcome all of you to the ACLP Journal Club. Dr. Reza is a clinical assistant professor at psychiatry at NYU Langone and assistant director of the inpatient psychiatry at Bellevue Hospital in New York. During training, she focused on perinatal psychiatry and OCD, and her work focuses currently on acute inpatient care with a special attention to both psychosis and women's mental health. She's the unit chief of an inpatient psychiatry teaching unit for NYU trainees. And I want to give an additional thank you for her because I think this paper ended up being more challenging than my very quick initial review had suggested. And I think it's going to make for a really interesting journal club and hopefully a good discussion. So, Dr. Reza.
Thank you so much for that lovely introduction. Um, so, as Catherine mentioned, I'm going to be talking about the correlation between mental health and the menopause transition. I'm going to be anchoring my talk on this particular paper, promoting good mental health over the menopause transition. This was part of a four-paper series that was done in The Lancet in 2024 that was focusing on rethinking our general approach to menopause with the goal of empowering women to manage this life transition. The lead author is based out of Australia, and the rest are from the UK, China, the US, and Canada. And this was a collaboration between Gyn and Psych. Again, the purpose of the overall series of papers was to try to counter what seems to be a recent trend of possibly an over-medicalization of menopause. At the same time, as Catherine mentioned earlier, I personally found parts of this paper controversial, with some bias. My fear is that in an effort to counter that over-medicalization of menopause, they may have contributed to oversimplification of a pretty nuanced subject. It's really incredible that papers like this led to greater attention in the media towards a very vulnerable patient population that generally is easily disregarded in society and amongst clinicians. And yet at the same time, I don't want to dismiss the symptoms that our patients bring up to us during this vulnerable period of transition. So, to make sure we're on the same page in terms of terminology, when we say perimenopause, we're talking about the period in a person's life that starts usually around age 47 and can last for years. And it includes the final menstrual period and the year after that last menstrual period. This is a transitional time period that is associated with the reduced secretion of ovarian hormones like estrogen and progesterone as a finite store of ovarian follicles are depleted. And in total, this time period can last about 5 years and can include symptoms that we know well, like hot flashes or insomnia or vaginal dryness. It goes without saying also that this time period coincides with other known events like midlife stressors, rises in health conditions, rural transitions. Um, the average age of menopause in the US is 52. Um, Briefly, if someone's final menstrual period is before age 40, that's considered premature menopause. This is a visual depiction of the STRAW Stages of Reproductive Aging Workshop plus 10 staging system, which is considered the gold standard for characterizing reproductive aging. I just really like this visual depiction of this critical time period of perimenopause. As you'll see in the rest of my talk, this is an important period where we can identify and potentially early onwards treat and kind of course correct symptoms that can become debilitating later on. And why this even matters is because menopause affects more than 861 million women worldwide, 64 million in the US alone. And with increasing life expectancy, more and more women will live up to 40% of their lives in the postmenopausal period. And yet, at the same time, less than 10% of US medical residents feel prepared to address menopause. So it is really important to take a little bit of time to focus on the subject that, it comes with historical roots. There's a stereotype that's gone on for centuries associating the uterus, the femininity with psychiatric symptoms, starting with the Greek word hystera, leading to the coining of the term menopause, and then eventually something that absolutely affects contemporary research and contemporary rating scales, the Blatt-Cooperman Menopausal Index. This was a widely used rating scale that, in its 11 items, included psychological symptoms like melancholia and nervousness in identifying menopause. So now we've come to this point where there is this generally prevalent attitude that the menopause transition is associated with both a physical and a mental health decline, maybe even suicidality, that's popular amongst our patients and amongst their treating clinicians as well. So this paper has a couple of objectives, and it's actually a very large topic that they took on. They wanted to review prospective studies investigating the association between menopause transition, henceforth I'm just going to call it transition, and the risk of mental health symptoms and disorders, then focusing who's at risk for MDD and depressive symptoms and what are their vulnerability factors, and then zooming out to think about the overall recommendations for the detection and treatment of these symptoms and how to promote good mental health over this transition. Their search strategy involved searching several large databases, including Medline, Embase, PsycInfo, for nearly a 30-year period using these search terms. For studies that were focusing on the absolute and relative risk of mental health disorders, they a priori had decided to focus on cohort studies with a sample size larger than 100 participants for whom they had prospective data on the risk of mental health symptoms before menopause and in that transitional period. And they drew from the largest sample size or the longest follow-up period. They cross-checked against relevant meta-analyses and systematic reviews. And they did so similarly when they were focusing on risk factors and recommendations, prioritizing whatever findings from prospective studies they could find and clinical guidelines. Goes without saying that as everything is in women's mental health, more high-quality research is needed. So, in response to this widely held association that I mentioned earlier, where women are diagnosed twice as often with major depressive disorder, and this was thought perhaps due to be endogenous sex steroid hormones, they wanted to focus on what led to this conclusion. And they pointed out that a lot of the popularly referenced studies and news and social media focuses on relative risk rather than zooming out and focusing on the absolute risk of any of these illnesses during this time period in women. Apart from an overemphasis on relative risk, they also noted that there isn't enough distinguishing between depressive symptoms, which are less debilitating, can fluctuate, can be for about a week, and very easily influenced by somatic symptoms of menopause itself, like sleep or appetite disturbance or fatigue or vasomotor symptoms, versus that of clinically diagnosed, clinically significant, and impairing major depressive disorder that includes symptoms lasting 2 weeks, including core symptoms of depression and anhedonia, and ideally assessed professionally through a clinician-rated interview. Um, in comparison, a lot of studies focus on depressive symptoms, often using a self-administered questionnaire, just because that's a lot easier to do, much cheaper of an assessment to implement. But even if you rounded up and utilized a higher cutoff in things like the Center for Epidemiological Studies depression scale, that only has a zero point 0.7 specificity for MDD. So you could still score for depressive symptoms due to the other multifactorial somatic symptoms and not necessarily for core MDD symptoms. Other confounders that are important and make it very difficult to disentangle the somatic and physiological symptoms include the fluctuations in sex hormones, metabolism, lifestyle, sexuality, health conditions, including cardiovascular risks, and role transitions. Across the studies that they looked at, it's obvious that there are some limitations. As I mentioned earlier, there's a lack of clear distinctions between symptoms, including distress or anxiety versus depression, inconsistencies in menopausal staging, and questions about the generalizability and applicability of this data, and overall few large interventional studies. So they looked at a total of 12 prospective studies. As I mentioned, with a sample size greater than 100 people, most of them focused on high-income countries, and only one was based out of China. Why this matters is because global differences in cultural attitudes towards menopause do influence a person's perception about their own symptoms. For example, in, let's say, a country like Australia, where there's a more predominantly white demographic, there may be greater fears of aging. And that negative association then can kind of become a self-fulfilling prophecy about what their menopausal experience is like. Versus in Laotian culture, where becoming older and achieving menopause is kind of considered a status update. Greater respect with aging, and overall affirming attitude. Of those 12 prospective studies, only two studies uniformly diagnosed major depressive disorder with clinician-rated interviews. And I'm not going to go into every single study, but these two were particularly important to highlight. And that includes the well-known study of women's health across the nation, or the SWAN study, and the Zurich study in Switzerland. Now, both of these had notably longitudinal follow-up, with 13 years for SWAN and 29 years of follow-up with the Zurich study. And both of them did not find it did not find an increased risk for first lifetime onset episode, but did note that in women who already had major depressive disorder, there was an increased risk of recurrence in this transitional time period. I do want to highlight that our understanding of this risk is limited to the data from these two well-done studies, which approximately total 600 women. But the SWAN study did show that there was a 2.67-fold increased risk of MDD recurrence, which is significant. Zooming out to depressive symptoms and not just major depressive disorder itself, they looked at the rest of the prospective studies. Two of them showed an association for increased depressive symptoms. Three showed no association, and the rest, seven, showed mixed results. Overall, it did appear that in this transition, there are greater depressive symptoms that are reported, about 50 to 65%, in people with a previous major depressive disorder. So that means that for people without a prior diagnosis of MDD, the absolute risk of depressive symptoms is not markedly elevated over this menopausal transition. And that is contrary to what is typically thought of. Specific subgroups that are maybe more at risk include people with a longer duration of menopause transition, so a longer time period of being in this kind of in-between state and experiencing those symptoms, people with a combination of vasomotor symptoms and adverse life events in the past 6 months, and people with a hysterectomy. I thought that this was a helpful graphic that was drawn from the Penn ovarian aging study. And it looked at, yes, there was a risk of greater depressive symptoms in this menopausal transition period, but most of that risk came from people who already had a history of depression. And overall, a minority of women, 10 to 30%, reported clinically significant symptoms amongst women with no prior depressive disorder. Whether this risk is ongoing after menopause or starts to climb down after menopause is kind of mixed between these two studies. So the article succinctly says that, in summary, on basis of mixed findings from prospective studies, they found no compelling evidence for a universal or uniform increased risk of depressive symptoms over this transition. Moving over to anxiety, which is something else that our patients often will bring up to us, especially because menopause itself can cause somatic experiences that are very similar to anxiety, like sweating, racing heart, rapid breathing. They looked at 4 studies, two which showed an association for increased anxiety in the transition, and two that found no difference. What is most important is that it seems like the physical symptoms of anxiety was correlated with then an increased risk of developing moderate or severe vasomotor symptoms. And there seems to be a bidirectional relationship, such that we could potentially make that the intervention, reducing anxiety to reduce the distress and bother from the vasomotor symptoms that are being experienced. Bipolar disorder did not have necessarily any prospective studies, so this was largely on the basis of retrospective self-reports, with the caveat that, this may, especially when symptomatic, this patient population may not have the greatest amount of insight, be the most accurate historians, might be also biased by the cultural expectations I mentioned earlier related to mood and menopause. But there were some self-reports and some studies that are summarized here, including in the systematic review, that showed that women did tend to report having greater perimenopausal mood symptoms if they had a previous bipolar diagnosis. I do want to pause briefly to bring in my personal experience and opinion that is echoed by a lot of other well-esteemed organizations like the Menopause Society. Women living with a serious mental illness like bipolar disorder or schizophrenia are particularly vulnerable to an exacerbation of symptoms during this menopause transition, and frankly, might be ill-equipped to even manage the physiological changes associated with this transition. So we really need to do our best as CL psychiatrists to provide that psychoeducation for the patients and their primary providers. Similarly, in psychosis, they did not find any prospective data. We often think about there being a bimodal distribution of diagnosis in women, and this is born out of the estrogen hypothesis, which suggests that a decline in estrogens across the menopause transition might trigger psychosis in women. There was some data that showed that women are more likely to experience their first ever psychosis after age 45, unlike men, and that these women may also be more likely to be hospitalized later in life compared to men. But it is just a hypothesis, and it's true that estrogen withdrawal doesn't occur uniformly at this age. Um, so they did not find that for there to be an association. Here too, I do want to just point out that just because there is a scarcity of prospective data doesn't mean that there isn't some evidence that's worthwhile exploring further. And I do hope that there is research that looks into this more because the evidence that is out there does seem to support that there is a greater frequency of exacerbations after age 45 in women. And it does make sense mechanistically that the estrogen decline could be associated, though again, that could be multifactorial. And overall, we just need to not ignore this vulnerable patient population. A lack of correlation doesn't necessarily mean that we kind of just ignore any symptoms that our patients bring up to us. And frankly, they may not be able to be insightful enough to bring this up to us. So we should also be soliciting what their experience is like in this transition in their life. Undertreating symptoms risks both a mood disturbance and neuropsychiatric sequelae. Moving over to suicidality. Overall, there was scarce empirical data to support the claims that there is greater suicidality in the menopausal transition. However, it's noteworthy that there was a large study based in Korea where there was increased suicidal ideation, even if not attempts or completion. Um, Also unclear in how to explain this, but US female veterans who were on menopausal hormonal therapy were associated with a significantly increased risk of attempted and completed suicide. Um, so, in my opinion, interpreting this data to me means that this is just a time period where women are vulnerable and there is potentially mood destabilization occurring. I just presented a bunch of different perspective data, so I just wanted to focus on what the article wants to get across, which is that based on the prospective data they looked at, the risk of first lifetime major depressive disorder is not increased over the menopause transition. But individuals with previous MDD might be at an increased risk of recurrence. Contrary to stereotypes that abound, women are not universally or uniformly at risk for depressive symptoms. And there are some subgroups that should have more attention paid to them, especially if they have a previous MDD or they've experienced very severe vasomotor symptoms or sleep disturbances, are experiencing a longer duration of the menopausal transition, or have other reproductive hormone fluctuations that might be contributing, and that are also going to be impacted by psychosocial stressors and stressful life events. Those are vulnerability factors for MDD. Overall, there was scarce evidence to suggest that the risk of anxiety, bipolar, psychosis, or suicidality is substantially increased during the menopause transition based on the prospective data. So, important predictors of depressive symptoms during the menopause transition include psychosocial stressors. These stressors, like financial problems, unemployment, poor social supports, stressful life events, can even impact sex steroid hormones themselves and modify mood. Other risk factors include adverse childhood experiences, being of a minority ethnic group, a higher BMI, traits of neuroticism, lifestyle behaviors like smoking or being sedentary, and negative expectations and attitudes towards menopause and aging. For example, significant worry about physical decline. All of these things can predict subsequent depressive symptoms. Menopause-specific risk factors include the type and timing of menopause. There is some data that there's a rise in depressive or anxiety symptoms that's transient, resolving in about 2 years following surgical menopause. But it's also important to note that here there is a lot of confounding variables. Women who have surgical menopause have other risk factors for depression, like adverse childhood experiences, abuse, chronic pelvic pain. Even women who experience spontaneous premature or early menopause are at increased risk for depressive symptoms, but they are more likely to have experienced already cancer treatment, infertility, and gynecological pathology than women who have menopause at the average age. Um, the longer duration of transition also does matter. The extent of the interference of vasomotor symptoms matters significantly, even more than necessarily frequency. So, being able to effectively manage nocturnal, severe vasomotor symptoms can positively impact the management of mood disturbances. Um, Unhelpful thinking, especially if someone's predisposed to anxiety, absolutely can contribute to distress, such as a fear that their symptoms will never end, or are someone who's very sensitive to noticing their entire hot flash, and perhaps greater estradiol variability and low progesterone is associated with low mood, but there's kind of mixed literature about that. The authors put all of this together in a really helpful visual that kind of drew in all of the different risk factors that I mentioned. And they wanted to emphasize that really there should be a personalized framework that considers a woman's previous history, hormone sensitivity, and all of these risk factors when we're looking at symptoms. So, how do we optimize mental health? To be able to identify symptoms, we have to vigilantly monitor in patients who are at greater risk, such as those with a history of MDD. But we also have to be able to address the fears that our patients might be walking into the room with, being able to provide clear statements, countering the stigma that exists, and making it so that they know that this is something that is being looked into, but doesn't universally mean that they're at a greater risk for psychological distress during this time period. We shouldn't assume that someone with psychological symptoms over menopause transition is automatically attributable to menopause. Like with anyone else, we should investigate and manage these symptoms and collaborate with their gynecologist, their primary care doctor to use evidence-based treatments to make effective interventions. We should be really thoughtful about discontinuing active treatments for MDD over this hormonal transition, the menopause transition, due to the possible increased risk for recurrence. And when possible, we should offer CBT, psychotherapy, especially during life events and midlife role transitions, and really kind of doing our best as CL psychiatrists to facilitate a larger societal change and education for clinicians and patients alike, where we're countering the harmful stereotypes that exist and trying our best to recognize if we're coming from a sexist or an ageist standpoint, because that could be contributing to, as I mentioned, the self-fulfilling prophecy of what the menopausal experience is like psychologically. So being able to focus on the people who are at greatest risk while recognizing that our patients are coming in with knowledge that they're getting from Reddit, from online social media, and even really reputable resources in public health have discrepancies in their messages and in their knowledge that's being presented. To be able to detect, we have to have an accurate understanding of the risk factors that are out there and the data that does exist. Menopausal hormonal treatment doesn't prevent or treat necessarily depression if it's just depression by itself, but it can be utilized to improve depressive symptoms in patients with bothersome vasomotor symptoms. The strengths and limitations of the study I've kind of already alluded to. The biggest limitation would be the lack of prospective data in some of the other types of psychiatric illnesses that they looked at, and that they had limited statistical power to detect an association. But they did utilize what evidence was there to be able to come to an overall conclusion that there are some populations that are at greater risk and some populations we don't know much about, like gender diverse people. So the takeaways are that their absolute risk has not significantly changed, but there are subgroups that are at greater risk, including women who have experienced um, major depressive disorder previously, or are experiencing severe and prolonged vasomotor symptoms, insomnia, stressful life events. And there are menopause specific vulnerability factors that we should be aware of. We should also utilize our role to address stigma and expectations and providing psychoeducation for patients and their primary clinicians to be able to offer evidence-based treatments, which doesn't necessarily exclude menopausal hormonal therapy, but does lead to us being thoughtful in not overprescribing it and using it judiciously, weighing the risks and benefits for an individualized treatment plan. For us to be able to do that, I think we have to have a better understanding of what resources exist, updating ourselves and our patients. I'm particularly partial towards the Menopause Society. I think they have great quick takes on the latest research and have excellent clinician guidelines. For patients, my Menoplan is also a great resource. Okay,
All
with
right,
that,
thank you, Dr. Reza. If anyone has any questions, please certainly put them in the Q&A section. Um, so I guess the big picture, because this is a very complicated article, like you said, and somewhat controversial. What would you like if somebody came to you with questions about menopause transition and their mental health? What would you recommend that clinicians and
if it was
how they
if
would
it was
educate?
if it was frankly, if it was a patient or a clinician who came to me as a CL psychiatrist, I would pause to validate their experience so far, as well as getting and diving in kind of deeper into what it is that they're experiencing. I don't want to over pathologize. I don't want to assume that something is just due to the physiological symptoms of menopause, and I don't want to miss an opportunity to intervene. And those interventions might include things that we already do as psychiatrists, like psychotherapy or utilizing antidepressants. But something that I think psychiatrists in general are not as well versed in because it's just not part of our training is being able to collaborate with the gynecologist on the selective and appropriate use for menopausal hormonal therapy, which some major organizations do recommend utilizing when there's depressive symptoms in concurrence with vasomotor symptoms.
That was going to be my next question is like, what's the role of HRT? How about the role of other medications um, and options?
This particular paper didn't focus much on other medications, and that was actually one of the things I wanted to bring up as limitations go, because it utilized cohort studies, yes, but it didn't really include as much of the intervention studies that exist. Small as the sample sizes are, there are interventional studies. For example, with psychosis, there's some studies that look into selective estrogen receptor SERMs, and that the data from those small RCTs shows that there's something there that could be potentially modified, whether it's for psychosis or bipolar disorder or depression. In general, most prescribers who are managing menopausal symptoms tend to lean towards antidepressants like paroxetine, which is the only FDA-approved antidepressant for the treatment of vasomotor symptoms. But they'll also draw on desvenlafaxine and other antidepressants. There isn't much data, and therefore not as often drawn upon in fluoxetine or sertraline, interestingly. But the other antidepressants are used, and there's different types of psychotherapy, including the potentially scalable group intervention of the mindfulness-based stress reduction, which is like an 8-week group intervention that could be useful in reducing stress, preventing depressive symptoms, and improving overall resiliency.
Great. All right. Well, I know we're up for time, so I thank everyone for bearing with us. If there's, and I'm not seeing any other questions, but I want to thank Dr. Reza for covering a really complicated talk and sort of summarizing what half the population goes through. So, all right. Thank
Thank
you.
you, guys.